And we have an amazing ultrasound researcher who I think we will all have a lot to learn from. So thank you. And so I'm just, for those of you who don't know me, I'm Lynn Rappolo. I'm I'm a retired professor from UT Southwestern, but I'm not that old, but I met criteria for retirement. So now I'm at John Peter Smith in Fort Worth. And before we get started, I think we have one of our other planners, Dr. Werner. You want to just maybe introduce yourself?
Sure. I'm Sandy Werner. I'm the fellowship director at Metro Health in Cleveland.
Awesome.
And I could be retired, but no, I'm still working.
I know. 5 more years. I don't know. I'm like my 5-year plan. And then Dan Mersch is here, but he's working clinically, so he has everything kind of turned off. But I'm going to say it now, and then I'll say it again at the end. If any of you are interested in being part of this group, I'm relatively new, and it's just amazing experience meeting a lot of people, learning a lot. So just let us know. So without further ado, we're going to be talking about 2 articles. We have the author of the first article, and I'll introduce him in just a second. But instead of, for those of you who have been on this before, normally we break into small groups, and we won't be doing that today because we actually have another guest, and we're going to just kind of present the article as a group and have hopefully an interactive discussion. But the other person is not the author of the article. She's actually a statistician who's become my friend, and she's just going to kind of help me present an article to you. So without further ado, I just want to introduce to you Dr. Gibbons, who has this amazing history, and we're so fortunate to have him here. He's a graduate of the Luke Katz School of Medicine in Temple, and he kind of did everything there. He did his residency there, was a chief resident, then did his ultrasound fellowship there, and then is an associate professor and director of ultrasound, the UME, and recently appointed as the inaugural endowed professor of medical education innovation, which is really cool. He also has implemented this 4-year longitudinal curriculum. He's the AEMUS fellowship director and associate director of the Division of Emergency Ultrasound in his department. He's just done so much. He has published over 50 peer-reviewed manuscripts, abstracts, book chapters. His work has been you probably have heard of it just on just medical journals, also a lot of our ultrasound outlets and podcasts that we hear. He's also a leader who we are so fortunate to have him so involved. And lastly, has served on active duty in the United States Navy, and I think he's still involved in that. So he's going to be talking about his article, and many of you have probably read it, and we sent it out to you, so you'll have access to that. But so just, Ryan, why don't you go ahead and get started? And do we just kind of want to just hear about your study to learn from how you did this, because we know research is not easy.
Yeah, and thank you for the very lovely introduction. And I have my crew signing on too. And let me first say, the study wouldn't have been possible or all that stuff without Tom Costantino, who's our mentor, and he might have something to add to the study. So yeah, I guess I'll kind of just, this is very informal, but I'll kind of start with where the idea came from. And if anyone was at SAEM this past week, during the Wavemakers talk, ultrasound research can be challenging to do. I think we've moved beyond a lot of like, hey, we can do this. Like I ultrasounded a gallbladder and we can do that. Now it's like, how does it affect patient care? How do we get into like randomized control trials? How do we do multi-center ones? And like I said before, Tom Costantino was my fellowship director and mentor, and I was interested in research, and he, to be honest, he had the idea. He had done a knee arthrocentesis one years ago, a randomized one between landmark and ultrasound guided, and had always wanted to do a medium small joint one. And there really wasn't one out there. There was a cadaver study that was published. And then there was an abstract by Vivek a few years ago that never was fully published, just of non-knee arthrocentesis. So, the thought was, it's not out there. It's something, we should try to conduct at Temple. It was one of our first ones. We did an A-line one as well that we randomized. So I think that's really where a lot of our ideas come from, looking for things that haven't been done and that will lend itself to, patient care, and, ideally, if possible, a randomization. So this was a single center prospective randomized trial of a convenient sample of adult patients presenting to our academic center. And initially, we were going to do medium-sized and small joint arthrocentesis, and we defined medium-sized as elbow, wrist, ankle, and then anything smaller than that would be smaller joint arthrocentesis. We were only able to get one small joint. I think it was the big toe. So ultimately, after we completed the study, we dropped small joint from it because we really just didn't have the data to make any sort of conclusions based off of it. So we kept with elbow, wrist, and ankle. And we ran a power analysis, and we would need, I believe it was 14 in each group, if I remember correctly. It's been a while since I looked at everything. We were able to enroll 23 into the landmark group and 21 into the ultrasound group. And the students that were not students, residents, were the ones performing the arthrocentesis and ultrasound, which, again, is not reflective of all EM practice. So that was one of the limitations. But what we ultimately found was ultrasound guidance was far better for not only overall success, but first pass success. We had fewer mean attempts. We also were looking at complications, which were predefined as far as like bleeding, hematoma, things like that, which we really didn't have any significant complications. So we can't make any sort of assumptions regarding, is one or the other safer. But ultimately, what we did see was ultrasound is better for first pass and overall success. The other interesting thing that I always like to tell our residents was our physical exam is abysmal for a lot of things, let's be honest, and that's what point of care is for. But for diagnosing effusions. And in fact, if you look at some of the literature, by Blavis and Shrikar from years ago, EPs miss 50% of the cases. So the idea is, like, why are we, using, physical exam when we have something so much better? And what our study showed, we were only 73%, we had 73% accuracy in correctly identifying effusion. So meaning there's a lot of people, if we're not using an ultrasound guided first approach, we're going to be, putting a needle into a joint space that very well might not need it. And if we're not using ultrasound, we can also potentially cause, vascular injury, neuro injury. So really, one of the things I love is the fact that, again, ultrasound is just better for physical examination. We should use an ultrasound first approach to not only diagnose it, but then once we actually have the effusion, to use ultrasound guidance rather than traditional landmark guidance. So, big limitations here. And again, I think a lot of our point of care ultrasound studies have these type of limitations, but it was single center, convenient sampling. It's tough to get everybody to buy into point of care. Not everyone is as passionate as this group is. So it was convenient sampling at one site. We certainly didn't have a large N because it's not, I can't say in our practice we come across a ton of medium joint arthrocentesis. So the small N led to wide confidence intervals, which limit validity. Other big things were we mainly did wrists and ankles. So over 50% were wrists, just over a third were ankles. So that kind of limits what we can say about elbows. Certainly I think there's room for if you were able to do a study just on a single joint, but it's tough to get that number unless you have a multi-center one. The last thing I'll say as far as limitations is, as far as how we define joint effusion, it's whether we saw something on ultrasound or did a dry aspiration. Certainly we could have been missing things because we can only detect about a cc or more on ultrasound. So certainly if we used advanced imaging like MRI, would we have seen an effusion or not? Potentially there are some that we had missed, but were they clinically relevant? Most likely not. The other things as far as limitations, we didn't account for anyone's experience prior to this, which may have influenced results one way or the other as far as landmark or ultrasound guidance. And we didn't account for any sort of guidance that was given by the supervising physician, because the way at least we run, our residencies, the residents are the ones doing the ultrasounds, doing the procedures. And there's some verbal guidance. Sometimes there's hands-on guidance. But part of the study was to limit any sort of actual tactile guidance, but we did not account for any kind of verbal guidance like, hey, move over here or try to redirect, which may have influenced success or failure. And then the last one, it's hard not to know that it's being run by the ultrasound division. We're always running around trying to enroll people and have them do ultrasound. So that certainly could lead towards a bias towards success with ultrasound guidance, knowing that we were the ones running the study. And then kind of what I've been hinting at lastly, just looking through all our limitations here, our ED is not representative of the broader EM community. Certainly, we have a very robust residency ultrasound division, and that may not reflect what other.
You still there?
Which may not reflect, clinical practice in other residencies or even community-based ERs. I think that's pretty much what I wanted to cover, and open it up to any questions or comments.
Thank you, by the way. I was, and this is, I'm sure, quite an undertaking with a bunch of residents in trying to do this while your emergency department needs to keep flowing. How did you get your residents engaged to, sometimes I can't get them to do an ultrasound.
I shame them I kind of do. I try to quote, literature now that we have done this study. So now I'm like, and I always pull it up. I'm like, there was this landmark study about arthrocentesis. And I'm like, oh, look at that at Temple. I like to show them the evidence. There's so much evidence out there that ultrasound is better than really any physical exam. And procedurally, more and more, at least at our center, everything needs, any central line, everything is ultrasound guided now. So I think, and that kind of mindset was in place when I got there. Our chief, Tom, has set up, all our faculty are credentialed. He's been doing this since the early 2000s. So I think it's just kind of a mindset that's already there that, we use ultrasound regularly. A lot of it was just more, having the faculty available to enroll and things like that. And actually getting the numbers were probably the biggest challenges. But I think, our residents are, so solid and eager to learn ultrasound that wasn't a huge issue for us. Especially from a procedural standpoint, everything I learned, I don't know what I would do without an ultrasound. In all honesty, I don't know if I couldn't get an IV. I don't know what I probably wouldn't be a doctor if it point of care didn't exist. So, and I think a lot of our mindset is that way at Temple. We're very ultrasound friendly.
Yeah, I actually have the opposite point of view. It's interesting. I was surprised that you even had equipoise to get people to not do ultrasound. I know that like you said, there's not a lot of literature on medium joints, but I can't imagine doing a wrist or an ankle without I can barely imagine doing a knee without having ultrasound. I just, it's crazy to me that you could even get people to not do ultrasound.
Yeah, and I think again, it depends on when you were trained. You know, I don't want to, you know, point out anyone's age or anything like that, but definitely like some of our faculty are like, oh, landmark, you can do landmark. And I think it's important probably to still have that skill set because, you know, depending on where you go, you might not have ultrasound, but I agree. I mean, like everything's just safer and most institutions are mandating that you use ultrasound guidance. So that this idea of landmark guidance is definitely is fading. And I think you'll just see that more and more as, you know, each, you know, I mean, med schools are teaching ultrasound, residencies and, yeah.
I was also actually referred to like because the ultrasound guidance with doing some of these procedures, I totally get. Thank God we're in that world now because I grew up without ultrasound, but just to, you know, the extra step that it takes to recruit the patient to be part of the study and to do all the things that you need to do with research in the clinical environment, in addition to all the other stuff that they're doing. And I didn't see like you didn't have like a ton of residents, you know, sometimes it takes getting them involved so that they can be champions for your study. I was just wondering if there was any, or is that the culture? Do you guys have lots of research clinically going on all the time? So it's, you know, not that out of.
Yeah, that's a good point. Like it varies. And we do have a research division. Like our research division is I mean, nationally, like Nina Gentile is our head of research, and she is nationally known. I mean, it does a lot of the, I mean, NIH funding, I mean, it's just unbelievable what she does, and their team. You know, our studies are smaller and don't always, you know, get the attention that they deserve. So it is a challenge. I mean, this took us, you know, I think it was 2 years at the time, you know, and Allison and Jess on here were our fellows at the time. And this kind of, you know, transitioned, you know, across a couple fellowships. And usually what we like to do is, especially with our fellows, you know, kind of get them on studies. That way they enroll and things like that. And, you know, at the time, I mean, we had close to almost double digit faculty that were ultrasound trained. So it was easier from that standpoint. Yeah, but I agree. I mean, you know, especially point of care studies, you know, because not everybody does point of care. There's a lot to it, getting the machines and consenting. It's yeah, I wish I had a better answer for you because we try more and more to get some support from our research division when we can. But yeah, these take a long time. Like we just published a dissection study, and I mean it was like 10 years to get a. I mean we enrolled a ton of people, but it can be difficult. And I think, you know, part of that talk at SAEM was how do we, you know, collaborate more. And I think, you know, places like SAEM and ACEP and AAEM, these are ways to get people involved in multi-center ones. I mean, you have what Rappolo does with the Reason Network, and there's opportunities out there. And I think that's, you know, the next step for point of care. We got to collaborate more to have these multi-center studies to get our enrollments up and have much more robust data. But it's a challenge. I agree. I mean, because a lot of it is just you're doing it and when you're available and if luck has it and the patient agrees, you know.
Any other questions, everybody? There's several people in here. I know there's some fellows. You're probably working on some research, probably some junior faculty. And Dr. Gibbons, you've done tons of studies, so I'm sure you have lots of just experience and some pearls.
Because what studies are you working on now, and what's left to collaborate for?
One we're doing right now is we're partnering with GE with an AI study. They're giving us their caption guidance. Certainly, I mean that would involve, you know, if we were going to do a multi-center one, getting the caption uploaded and stuff like that. But it's basically like does it help teach cardiac ultrasound to our students and residents? And we're going to be randomizing them. Like some get the caption, others don't. And then they'll have an OSCE at the end to see if any of this AI stuff, works out. The other study is we are looking at trying to eliminate or reduce CAT scans for kidney stones. So we are using ultrasound urine and comparing it to gold standard CT. And if we have a negative urine, negative hydronephrosis, can we just exclude, kidney stone altogether? And then at least you're not, CAT scanning for at least a stone in those indications. Not that, I mean, you can argue the utility of actually getting a CAT scan for just your routine kidney stones, which I'm not a huge believer in, but at least I still know it's a very common thing. But at least if you can go in the room and be like, hey, you have no hydro, you have no blood, at the very least, we're not CAT scanning you for a kidney stone. Are we worried about something else? So we're enrolling for that. And, I've reached out to some colleagues about multi-center ones or to collaborate with us. So and we have a few other ideas in the pipeline, but we're always happy to collaborate. And I don't know if my email's out there. I'm sure it is. But you can reach out to me offline anytime.
That's one benefit of this group because we're all interested in the same thing. And so, I mean, you're probably here because you're interested in research or you're doing research. You want to further your knowledge, but just to kind of network and collaborate on studies because those are, as we know, more powerful and more publishable. So anybody else, any other questions? I'll comment in the chat that someone said they love your study. It supports what we do clinically. I had somebody with a big knee septic joint had ultrasound show my needle in the joint. This is when I was at my old job, and ortho came by and said, and redid it. No, they wanted to. I'm like, I'm like, because that's what they always did. They did that before ultrasound because emergency medicine didn't know how to do an arthrocentesis. But anyway, we converted them, so that didn't last very long. But
yeah, we had a workshop at SAEM that my fellows helped teach, but we were, showing how to do ultrasound guided arthrocentesis. And like one that we, I don't know if everybody is, but I was like traditionally taught like, oh, we don't do hips, only ortho does. And I was like, I don't understand that. Why is that? And I've done a few now and I'm like, this one, couldn't be more amenable to ultrasound. And it was so easy. And I'm like, so I think, the more we, utilize point of care and get studies like this and other great studies, really kind of change the way we practice for the better.
But how do you win? So our orthopedists are just barely coming around to the thought of the ultrasound might be useful. And we've gotten some agreements with them for nerve blocks, but typically they don't buy into ultrasound. And if they're going to come down and tap a knee and it's somebody who's had an artificial knee because they don't want us tapping those, they refuse to do ultrasound. And it's like, it's suprapatellar. You're like in the wrong place.
Send them Dr. Gibbons' paper.
Well, I mean, yeah. And again, I think as we have them coming from out of med school now that know ultrasound, I think it just takes time. I mean, because again, even with EM, when it first started, people weren't buying into it. And now I look at our internal medicine colleagues, they're doing point of care. I think it takes a long time, but start small, because we did the same thing for like when we do nerve blocks, they were like, don't be doing, and then we just started with fascia iliaca, and then little by little, like small little baby steps. But yeah, I know how hard-headed some of the specialists can be.
Actually, the younger ones are more amenable, so those are the ones to approach. Yeah. It's your older attendings who didn't grow up with ultrasound. So, well, this was fantastic. Anybody else? Any other questions? Well, we appreciate you. Are these your fellows in the corner?
Under Tom. Yeah, they're waving.
Yeah.
Right. So they were
Okay, you
there
guys are
helping.
so lucky to have Dr. Gibbons.
I think more lucky to have Tom and Mark, I'll be honest. They know what I'm talking about.
Let's see, and then somebody just said, I've really been impressed by the ortho PAs in our practice setting who have embraced it. There we go. Yeah. And newer kind of generation because they were introduced to it in their training, definitely. So, yeah. So I didn't do a fellowship till 4 years ago after being part of the residency forever because I was so envious of our residents and how awesome they were and the things that they could do. So instead of just when they'd say, hey, Rappolo, what do you think of this? I'd say, well, what do you think? You know, when you say me, you don't know the answer. And so anyway, I saw the light and I was able to do the fellowship. So anyway, well, thank you so much, Dr. Gibbons. We know you're super busy and it's just a thrill to have you here.
Thanks for having me.
And you're welcome to stay. We're going to kind of, we have a second paper. And so I'm going to be presenting it. I have some slides and I apologize to bore you with some slides, but I had communicated so much with this author and was hoping to get him here, but it is 2 a.m. his time because he's in Australia. And so he also did an RCT. So yeah, when I first started looking at, I'm thinking they assigned me to musculoskeletal. Am I going to even find anything? So I was just absolutely thrilled that I was able to come across not one, but two studies. So let me just talk about this unless anybody has any questions. So there's a group that, I don't know, let me just take this off. Is it on slideshow for you? Because I don't have any notes. So, or is it on a regular view? Is it on a regular view for y'all? Does it look normal? My slides? Let's see.
It's on slideshow mode.
It's on regular mode, right? Okay. Okay. So anyway,
Lynn, we see your presenter mode.
Presenter mode.
Oh,
Yeah.
okay. All right.
There you go.
Good?
Perfect.
Okay, awesome. All right. I don't know why it defaults to that. So anyway, so there's a working group called Buckled, and it's an acronym, and I'm sure they spent a lot of time just coming up with this. But so, bedside ultrasound conducted in kids with distal upper limb fractures in the emergency department. And so I just wanted to introduce you to Dr. Peter Snelling, who I literally probably exchanged 20 emails with him over the last several days because I was really trying to come up with something. And even we were thinking about Zoom. And so we're going back and forth because he's committed. This has been like 5 years of work. And he has produced several publications that kind of led up to the study that we're going to talk about. And so first he did this kind of like study protocol and he published that. And then he actually had a article in the New England, in JAMA on what was originally looking at radiography and using ultrasound and looking more like kind of functionality, like when they injure themselves sort of thing. And so this study that you're seeing here was in parallel to what he was doing. New England Journal of Medicine was in parallel to the study that we're going to talk about today. And this is a study that we're going to talk about today. Diagnostic accuracy of point of care ultrasound versus radiographic imaging for pediatric distal forearm fractures and an RCT. So 2 RCTs kind of at the same time, but having like a different primary and secondary outcome. So, journals, as you know, when you're publishing this kind of stuff, when you're doing this kind of work, planning. And his paper, his work, checks all these boxes. And so that's why he was able to publish in these, nice journals. It is also, as we noticed, that higher end research is also frequently supported by grants. So he's had several funding. So we were going to Zoom. So this was, I don't know, the day after SAEM, I went to Tucson to have kind of like a get together with my friends. So here he is, he's actually on vacation with his family, but he said, I really want to do this because I just love your group and let's just make this work. And so, and finally, like all of a sudden he says, okay, I've got this 3-hour interval. He's traveling with his kids, and how unpredictable they are. But so when he messaged me, I was a little karaoke with a bunch of people. And so anyway, but I told my friends, I need to meet with this guy. And so I was all set, 5 minutes to showtime. and something happened and he had to pull the plug. So unfortunately, we weren't able to Zoom, but fortunately, I have Christine Ramdin here, who is a PhD biomedical statistics from Rutgers. And I know her through SAEM. I help coordinate the research learning series. And if you don't know about this, it's a lot of just videos on the SAEM website, a bunch of people, like usually 3 or 4 people from all over the country focus on a specific research topic. And she's been there doing some statistical talks and is actually going to be doing a Stats Made Simple series starting in July. But I thought I would bring her on since we couldn't have Dr. Jennings. So we're going to talk about this study. The primary outcome is the accuracy of clinicians' fracture diagnosis, but comparing it to an expert panel. And I'll talk to you about that. And then the secondary outcome is the diagnostic test performance characteristics. And so I have a slide just up here of really what they were looking for. You know, was it normal? Was there a buccal fracture or was there a cortical break? And the big concept here and the goal was really to let's get them out of the ER, get them home sooner. And so, buccal fracture are, kind of like minor fractures and could be managed conservatively. You don't need to do any intervention. And so if they had a normal or buccal fracture, those were the ones that just kind of, went home and simple that you can just diagnose with ultrasound was the big thing. And then he does some test performance characteristics comparing it to just a regular x-ray. So as far as the study design, it's open label. You can't blind people to what kind of imaging study that they get, but it was a diagnostic RCT. And they did it from September 2020 to November 2021. And it's a multi-center trial, so those are, again, empowers your study, makes it more publishable. But it was a convenient sample because they also, I think the main site was a pediatric emergency department. And they, with over 100,000 patient visits a year. I do want to mention, and this is something just important for ultrasound studies, is, you want to put in your methodology enough detail, but make it still, succinct, but that somebody can come along and reproduce it. And so it was nice that he actually included his training, and he actually did a study of this to determine how many they needed to do. But he included enough details. So they're 2-hour training course. They viewed 20 total ultrasounds and identified 10 fractures sort of thing, image bank assessment sort of thing. But what was interesting is he was the only one that had prior POCUS experience, and the other ones were non-physicians. They were 4 nurse practitioners and 1 physiotherapist were part of his 6-person team who would do these ultrasounds in their busy emergency department. The inclusion criteria was they had to be old enough to point to this is where it hurts. And that's where they did the ultrasound, and pediatric patients, of course. And then they had to be suspecting that there was potentially a fracture because they had an injury, it hurt, they had focal pain, but not some obvious fracture where they were going to be needing to have a reduction or surgery sort of thing. And these were all distal forearm fractures. This is him. And another thing that he did that was kind of innovative. So they had written consent, but while people were waiting in their busy emergency department, he had them watch a video. And so everybody that came with a suspicion for a fracture watch this really simple video, but it was very informative. And then when they came back, and if they met inclusion criteria, they were consented and then enrolled in the study and then subsequently randomized. So we'll just talk about the randomization. This is where I wanted to bring you in, Christine, because what he did was one-on-one block randomization, I think with 6 people in each block. So I just thought we would pick your brain and you can just kind of tell us about that.
Yeah, sure. So block randomization, especially in emergency departments, is really convenient, right? Because when you come into the emergency department and, with all the craziness and everything that's just going on, it becomes really difficult to spend your time opening a random number generator or flipping a coin to decide what patient gets what intervention. So designing the study in this way is just easier in that if you have blocks per day, and each block has a certain number of patients. So I think in this study, they were enrolling 300 patients. So they divided it into I guess how many days per year they wanted to do the study. And they divided it so that each day they can have a separate block of patients, how many patients they were planning to enroll in that study per day. And, the blocks are predefined, right? So either they want, they'll say that, okay, I want 3 patients that are in the intervention group and 3 patients in the control group, regardless of the order. But in this block on this day, like, we have 6 patients and 3 are going to be intervention, 3 are going to be control. And that gives like, providers liberty to like, not have to flip a coin or like, use a random generator every single time a patient comes in. So it keeps like things under control and yet at the same time kind of feasible, so that, we can get what we need to have done, and it's not, we don't have to think too much about it.
Awesome. Thank you. Anybody have
You're
questions, by the way? This would be an informal discussion. So if anybody wants to like have a question, and I'm not seeing the chat. So Sandy, if you see anybody, if they post something to ask Christine about. So now's your chance, guys. You got an amazing statistician with.
So yeah, I haven't done one like this, and I'm curious about how, so within the blocks, then how do you randomize it? So you have this block, and the block, say it's going to take you 5 days to get 6 patients. I don't know, it would in my ED, because we're not all peds. So how do you randomize it within that block?
So here's the thing, before the block even reaches you, the emergency department in question, that is supposed to be pre-specified. So if they wanted to randomize the block, they would have already done it, or they would just say that, okay, you're going to enroll 6 patients these days, and it's up to you, whatever order it is, you can do 3 control or 3 intervention. So either they'll leave that up to the provider, which makes it a little bit of a weaker study because, you can introduce bias that way, or they would have pre-randomized it.
Okay, yeah, I was curious about that certainly does introduce a little bit of bias if you're allowing just kind of, you figure out how to randomize them. Okay, thanks.
You're welcome. Thank you.
Awesome. Anybody else? Okay. All right. So this is what they did, and this is also what you want to include in your study to account for every single person who could have been potentially eligible. And then also you see the box on the top right about all the people that met exclusion criteria. And so, just anybody with any obvious fracture, wasn't in the age group sort of thing, anything like really a significant type of injury. And then they had 270 people, and then they were randomized. You could see what some of them, had an initial diagnostic study as an ultrasound versus an X-ray. And I think this is really good because I try to do a study like this in a pediatric emergency department to see how good students were at identifying the fracture, but then the people already had the X-ray, and you'd hear all this, has anybody done whatever for the radial fracture in room 12? You know what I mean? So it was so hard, and that was just, something that was a limitation. You do the best that we can do, but that was just kind of sloppy research. But anyway, so here you see, and then what was interesting is then after this, the gold standard was actually review by an expert panel. And that was a nice balanced panel. They had Dr. Jennings, I believe, and then they had a pediatric radiologist, and then they had a pediatric orthopedist. And that was kind of the gold standard. And then they went through with all the data, and I'll go through that in just a second. So they did do sample size calculation, which, it's not going to kill your study if you don't have a sample size calculation, and if it's not powered, so many studies, they write that in their limitations, but this one did the right thing, and they were able to do this ahead of time and recruit the number of patients that they needed. So Christine, you want to talk about this real quick? Just
yes,
because this always comes up.
Right, absolutely. So they did, and this is what gets it usually published in the higher tier levels, level journals, if you have a formal sample size calculation. So there's actually several different types of formulas based on your type of outcome that you can use to come up with your sample size. And these formulas usually have underlying assumptions. But as one of our previous stats videos with what I did with Dr. Ehrman, usually a journal will take something better than nothing as some type of calculation. So it's always good to have some type of sample calculation. Now the right, and when I say right, it's usually the accepted way to do it is, all these formulas have, certain criteria, certain inputs you have to put into the formula. And usually one of the inputs is, okay, what was the finding of a previous study? Or what do you anticipate, like, certain measures to be like, so based on the previous study, the certain metric or what was the outcome, and you would have to input that number into the formula, whether it's a proportion, whether it's a mean, whether it's a continuous variable, whatever not, and that would give you your outputs to calculate for for a particular study, for you to repeat your study. Now, in this particular study, they did not have a previous value. What they did is they took a value from one of the concurrent trials that they were running to power their study, which is completely acceptable. But, you know, in cases that, you know, they didn't have that kind of data, what I've seen some studies do, they've also, like, you know, estimated what they anticipate the effect size would be, or what they anticipate that outcome would be. And then, you know, as long as you do that and then you explain why, you know, you think you anticipate it based on previous literature or based on, like, you know, some preliminary data you had, that usually a journal will take that. Usually the other route to go about it too is, you know, also if you don't have, like, you know, any data at all, or you don't feel comfortable estimating, it's also okay to, like, you know, select a number, say 100 patients, 200 patients, whatever is feasible, and you call it a pilot study, because, you know, simply nothing has been published around that, and it's difficult for you to come to, like, you know, a conclusion of what that outcome would be without knowing what the outcome would be, and that's why you're conducting the study in the first place. So it's perfectly acceptable to, you know, call a study pilot and, you know, come up with a number that you could use for a sample size. And, you know, you just justify that in your methods section, stating that, you know, there was no preliminary data. And that's why we're, you know, using the sample size and calling it a pilot, which could be used as hypothesis generating the results of the study for future studies. So those are just some methods of addressing that. Obviously, probably that type of study, who knows, but it probably won't get published in NAGM because they're probably looking for that formal sample size calculation, but you have to start somewhere.
And they're all powered to 80%, right? So you have an 80% chance of, if there's truth in your study, that you will find it.
Right, absolutely.
Okay, so here we go. So here are the baseline characteristics that you have to report. And so with, you know, you can see that the groups are similar. They had exactly under 35 in each group. And so my question for you is, so I understand Consort does not want or recommend that we report like statistical testing of these baseline differences. And so I just was curious, because some people do still report them. I think more people are not reporting them, but I don't know, it just seems like the guidelines for reporting are saying don't report them. And so I don't know, I just thought it might be an interesting brief discussion.
Yeah, no, definitely it is interesting, because I've seen it both ways in articles. I've seen some articles report and some articles don't report. And actually in our own journal clubs in our emergency department, this becomes a question, right? Like if we're looking at a table and then we're like, well, how do we not know that if the control population is actually similar to the intervention population if there's no statistical testing? So then you just look at the numbers and kind of have to make an assumption that, you know, maybe this is not statistically significant, or it's just close enough that we don't have to think it's statistically significant. So one of the reasons why the guidelines probably say that, so there's actually probably a couple things here. Number one, I'm sure you guys have heard of multiple testing, right? All the statistical reviewers, when they come back, say that, you know, did you control for multiple testing? And what that essentially means is that if you do too many, you know, tests to a data set, like essentially you're introducing error into that data set, which kind of like nullifies, like in some way, your findings. So that could probably be one reason. The other thing is that I think another reason why there's been a push against it is because, you know, just because the groups may or may not be statistically significant from one another does not necessarily mean that, you know, they're not impacting the results somehow. So, like, you know, when we see these studies, oftentimes they say that, you know, we have our outcome, but we also adjusted for a gender XYZ. This is the way that it's more accepted. So like this way you're not comparing against each other and then also doing the regression finding. It's just sufficient probably to do the regression findings to adjust for those confounders, because it's a bit stronger and it gives you a bit more information to tell you that, you know, what impact each of these variables have on the results. So, you know, just not by doing it both ways, you're like, number one, you're not introducing multiple error. Number two, you're adding more useful information. Like sometimes it just doesn't suffice to say that, you know, the groups are different or they're similar to each other based on a variable, but maybe this variable may be affecting the outcome in some other way that we're not accounting for.
Thank you. And also, I mean, if you randomize appropriately and you power your study, it just doesn't become an issue. But any questions on that? Thank you. Getting a little statistical lessons today. You didn't realize you're coming. You're going to get more than just discussing this amazing article. Okay, so this is its protocol. So it's a modified 6-view forearm POCUS protocol that they did on everybody that got an ultrasound. So distal radius and ulna, and then they looked at the dorsal, lateral, and volar aspects. Of course, they used the high-frequency linear probe, the longitudinal axis with the probe marked distally, just so that was clear and everybody did it the same way. And then they looked also for secondary signs, and I'll go into that in just a second on why it's important. So here is basically the criteria for consideration of X-ray imaging after they did the ultrasound. So the primary one was if they saw a cortical breach, and so that was kind of considered, oh, they need an X-ray, so they went into that category. But then there's the list, and I'm not going to go into this, but just a list of other things that they might see that would also kind of put them into that group that got an X-ray. Now, that X-ray was not to change their original ultrasound finding kind of thing, how it might influence. I thought that was really good that they didn't change that. And then as far as management, as I had mentioned earlier, so if they had no fracture, because they still injured their arm, that's the reason why they're in the emergency department, because they had some pain, or if they saw a buccal fracture, they're basically treated almost the same. And for no fracture, it was at the provider discretion, versus if they had a buccal fracture, they all got a wrist splint. And then other fracture, it just, depending on the situation, they might have required an intervention, but they typically got a plaster cast. And then for the people that had no fracture or buccal fracture, they were followed up and reevaluated if they weren't improved. Because, so if it was something minor, they should have gotten significantly better, or maybe they missed a fracture, sort of thing. And so it was open label. There was that expert panel that determined the final diagnosis, but they were masked to the primary and the secondary outcomes. And so here's the panel that I had mentioned. And so they had access to pretty much everything, a retrospective review basically of all this data, clinical data, imaging data, follow-up data, management sort of thing. And so the interesting thing, because this always comes up in ultrasound studies, like they'll say, two people reviewed these, and if they didn't agree, then a third person agreed, which really isn't as scientific. It basically says that, two people agreed and one person didn't. And so the way that they did it, where they all had to independently review these, and then they all had to agree. And if they didn't all agree, then there was a lengthy discussion to kind of, and that's just, the best that you can do. But I thought that was very interesting. And I think it was more convincing than the other way that I told you about. So what do you think, Christina? Was this good enough? Or should they have done some kind of iterator reliability more formally and independently, did a rubric and calculate, those kind of things? So what do you think?
Yeah, so blinding, this is what I put in, it's difficult, right? Because no study can be 100% designed perfectly. So this is what I have to say, given that I'm not clinical. My take on this is that if you're doing all that you can to blind, that's probably good enough, right? Because there's certain situations when you're doing a study where it makes it impossible to blind, right? Obviously, for probably certain meds or certain clinical procedures, you probably have to get consent from the patient or whatever not, so which makes it impossible to blind. So I guess in this scenario, it's adequate unless any of you see an exception somewhere, which I'm not sure about, but otherwise it seems pretty good. So blinding as much as you can, we all want the triple blind perfect design experiment, but in some cases it's just not feasible. So blinding whatever you can feasible is usually acceptable. And if it's not feasible, then we just have to explain why it's not feasible. Sometimes it's just impossible. Now, inter-rater reliability. Yes, when we have multiple people abstracting charts or conducting a procedure, we should have an inter-rater reliability calculation. And inter-rater reliability, you can literally do this calculation for any type of variable you have, whether it's a continuous variable, whether it's a, a binary variable and whatnot. There are several different kappas and several different, types of variables that I'm not going to go into here, but like, as long as you have an inter-rater reliability calculation, if you're multiple people are doing something, like if they're doing an exam or not, and you have multiple measurements, you should do an inter-rater reliability calculation. That increases the validity of your study. It increases the validity of, the instrument you're testing or the point you're trying to make.
Awesome. And another way I think you can do this is just, and how I've done it is just taking 10% of my total sample size, because I didn't want to review 500 scans, was just to have, we did that inter-rater reliability on that. And then we reviewed all the other scans and only had one person review them at a time. So we didn't all have to review that many. So anyway, thank you. Any questions, guys? Anybody? Nope. Okay, so let's go to the exciting part where we talk about the results. So these are the diagnostic findings by treating clinical diagnosis versus the expert panel. So you see the expert panel diagnosis on top, and then they divided it into the point of care ultrasound group. And then below is the radiographic imaging. And you can see like 98% versus 81%. So of all the people that the expert panel thought, for example, had a buccal fracture, then, that was caught on ultrasound, which was pretty awesome, which was higher than you saw in the radiographic imaging group. And then as far as diagnostic accuracy, here's another one. So you can see they stratified it, point of care ultrasound, then you see the radiographic imaging, and then you see like the outcome on the left. And then, so what was interesting down below is and this is actually probably a very simple statistical calculation, but anyway, it just a difference in the right side of the column. Do you have any comments on this, by the way, Christina? It's like super easy. You just like subtract this.
Yeah. Right. So like, yes, unless I think this really comes down to reader perception and what the reader thinks is more valuable, because absolute difference is really just simple subtraction. But like, there's other ways to analyze this data, right? So like, for example, if we wanted to look at a relative difference to see how many more times I don't want to say the word likely because that gets into a whole other thing of like likelihood ratios and stuff, like how many more times this is like a multiplier of another that can also provide valuable information. There's also, statistical testing that could be done. Like if we're looking at diagnostic accuracy, some tests that come to mind are like, maybe you want to compare the sensitivity and the specificity, or you want to compare the positive predictive values and the negative predictive values. So, and then there are ways to like statistically compare them. So I think it really depends on the perception of the reader and like, what do they think would provide a lot more valuable information to, portray the data the way they want it to be, because, it becomes difficult because otherwise people will say that, you're just applying all these statistical tests to make your data seem the way you want it to seem. So I think at the end of the day, you just have to kind of choose the test that you think will present the data like in the most simplified, most accurate way. And these other ways you can provide it as well by providing different values to just show people what they are, but like you don't have one kind of focus. So I think what we think for like a given type of point, like if they're just looking at for diagnostic accuracy, I'm not sure what is the, I'm not from the ultrasound world, so what is like the accepted way of like comparing, but like if this is what's generally accepted and this is what people have a better time understanding, and there's no problem with it, just feel free to go ahead with it. But there are different ways you can compare your data.
And then for no fracture, thank you, by the way, Christine. And no fracture, by the way, was not statistically significant across this one here. Okay, and then lastly, here's just some more on diagnostic statistics. And so what it seems is just, it was more, I guess, specific than sensitive when you compare the two. And I think I said adjusted difference. I meant absolute difference. I do that a lot. I think I'm old. I substitute words. So this was kind of cool. The expert panel achieved unanimous individual consensus for 84% of the participants. So I thought that was awesome. So they're independently reviewed everything and they agreed 84% of the time. Any questions or concerns or thoughts to add in addition to what you've already said, Christine, about the analysis?
No, we see, and
It's pretty
again, this
simple
is
and
the huge,
straightforward.
huh?
It was pretty straightforward.
Yeah, it's pretty straightforward, and that's usually like it's usually the right thing, right? Because if you think about it, like if you're trying to use a more complicated statistical test, you always have to think about what more are you adding to what you're saying if you're instead of just using like, you know, the basic simplified test. So like I didn't see any issues with the analysis in terms of like, you know, large things that we think about like power calculation, like, you know, reporting of results, etc. I couldn't think of anything they could have adjusted for. Now that could have been a problem. If you guys felt they should have adjusted for something, then that could have been done. Otherwise, like, you know, in general, the more simple you can keep it to get your point across, that's probably usually the best way to do it.
Yeah, I like it. Keep it simple. Okay, so there were some limitations, as we know. I mean, there was a convenience sample. They had a variety of ultrasound machines in the emergency department. The time to perform the exam and interruption in workflow, like what did even that look like? They did have a research assistant, by the way, that assisted. They used to recap to put in their data. So, and this was a funded study, so they had a little more support than we probably have in our like, real world trying to do this. It was a very heterogeneous group, and then just unclear about how many ultrasounds were actually performed by each provider. You know, because Dr. Snelling was part of this. So those are the only ones I can think of. Can you think of any other ones that I didn't include? Nope. Okay. Anyway, so any questions, any additional comments? Let's see what's in the chat. Somebody said it'd be interesting to look at the time for POCUS versus sending to Radiographic. Yeah, definitely. That's actually a really good point. All right. Well, thank you all. I wanted to just put something, it's not here. I had a link to share with you, but I can't find it. If any of you are interested, my email was up here. Let me just put it, if any of you are interested in being part of this group, here is my email. Can you guys see it? I think I'm still sharing. Hope you learned something. This was a different format, so would love your feedback. We normally break into groups and then we kind of like come together and talk about it as a group. So thank you, Christine, for being here with us. I think you have like maybe 10 more minutes you can stay on if any of you had any just statistical related questions. The latter part of this session with PTL, we go over or just kind of open it up to discuss your research and anything that we can help you with, or give you advice about. And I love that Christine's here, so she can talk about some of the more complicated stuff. But if any of you wanted to just share anything or have some projects you're working on and you're looking for collaborators, would be also the forum to discuss anything. So otherwise we're done, but we're here if you wanted to talk about anything. So. All right. All righty. Well, I guess that's it. All right. Well, thank you all. I hope you enjoy the rest of your Tuesday. Thank you so much, Christine. We appreciate you. And it's good to see so many of you on with us today.
Thank you so much, Lynn.
You're welcome. Bye. Take care, everybody.